welcome to Osteobites. My name is Christina Iptoma, and I am mom to Osteo Angel Dillon and Director of Scientific Programs at MIB Agents. And today on Osteobites, we are talking with Dr. Ben Hoang about the SCF-Skp2 protein complex as a therapy for osteosarcoma by blocking the mutational effects of RB and P53. Thank you so much, Dr. Hoang, for joining us on Osteobites today. We're thrilled to have you. And also thank you to our panelist, Walker, for joining us today. Walker is an osteo warrior, and he's also Vice President of our Junior Advisory Board this year. So a little bit more about our guest today. Dr. Ben Hoang is a board-certified orthopedic surgeon specializing in musculoskeletal tumor surgery. He's an expert in benign and malignant tumors, metastatic bone disease, pathologic fractures, complex bone and joint reconstruction with large segment prosthesis and allograft, and tumors of the pelvis and sacrum, and investigational therapy for bone and soft tissue sarcoma. He's the co-director of the Orthopaedic Oncology Division at Montefiore and professor of orthopedic surgery at Albert Einstein College of Medicine. Welcome, Dr. Hoang, and welcome everyone joining us today. Please feel free to add any questions you have for Dr. Hoang in the Q&A, and we will be sure to ask those. And before we move on, some announcements and reminders. Our Factor Conference is June 22nd to 24th in Atlanta. Registration is now open, and our agenda will be up on the website shortly with our full list of speakers. We will have 6 scientific panels this year, and they will be on biomarkers for risk stratification, preclinical models, comparative oncology, local control, immunotherapies, and molecularly targeted therapies. And we're super excited this year. We're going to have 3 smaller breakout discussion groups. One is on researcher's best friend, can dogs expedite bench to bedside for pediatric patients? We'll also have a group on leveraging computational biology to accelerate discovery. And then we'll have a third group on turning pain into power, patients with osteosarcoma who enable research. And that discussion group will focus on engaging patients to power research with their data and samples, and would love patients and caregivers in that group as well. So Vector is really a fantastic opportunity to network and collaborate. Osteo warriors and caregivers can meet and just find a community that gets it. And scientists and clinicians can find opportunities to collaborate on research and also clinical best practices. And then we also have this great interaction between the patient caregiver community and the scientific community, and they just really kind of inspire each other. So we always say that you'll come to Vector to collaborate and you'll leave inspired. And then also, I just wanted to note that this weekend on Sunday, we have a Healing Hearts workshop for Osteo Angel siblings. It's going to be on April 30th, which is this Sunday at 7 Eastern. It's led by grief counselor Lori Krause, who's amazing. And these workshops are free of charge to all bereaved siblings of Osteo Angels who are at least 13 years old. And I will put some more info in the chat about how to get more info or how to sign up for that session. All right, Walker, could you please introduce yourself?
Yeah, my name is Walker Smallwood, and as Christina already said, I'm the MIB Junior Advisory Board Vice President this year and an osteo warrior. And today I'm really excited to hear what Dr. Hoang has to tell us. So Dr. Hoang, you can take it from there.
All right. Thank you, Walker. Thank you, Christina. Really a big thanks for all of you for inviting me today. It's really an honor to be here. I've been working on osteosarcoma probably for most of my career. Let's say it's spanned over about 20 years plus. But we've been working on this project for the last 4 or 5 years or so. It's very exciting, and I want to share with you some of the data today. So before we start, I just want to make sure to have my disclosures here. We are obviously very thankful for many of the organizations that support us over the years, and obviously for the research that I'm going to talk about today. So as we all know, osteosarcoma is the most common bone cancer in children and adolescents. Although the incidence is not very high as some of the adult cancers, we know that the morbidity and mortality from this disease are really tremendous, especially in the pediatric population. So for many years, there's really no new therapy that changes the clinical outcome of these patients. So, osteosarcoma, like many other cancers, has a very complex tumor microenvironment with many different types of cells. So to understand malignant bone formation, we really need to understand normal bone development. So in normal bone development, what we see are the mesenchymal stem cells, which differentiate into pre-osteoblasts, osteoblasts, and then osteocytes. And then there are transcription factors such as allosterics or OSX, rungs, and some of the components of these pathways called the Wnt signaling pathways are also very important in this process. So in osteosarcoma, what we see also is that major tumor suppressor genes such as RB and P53 are often inactivated. This then leads to genomic instability, even hypermutations, and some examples of breakage of chromosomes that are very, very extreme. Some also thought that this represents a defect in the osteoblast differentiation program, which then leads to less apoptosis and more proliferation. So just like I mentioned, two of the major tumor suppressor pathways are RB and P53, and they are often inactivated. So in the older literature, they seem to suggest that P53 inactivation rate is about 30 to 50%. With whole genome sequencing and modern genomic sequencing, we now know that the rate of inactivation of P53 is probably closer to 90 to 95%. And then if you talk about co-inactivation of both RB and P53, it's probably somewhere between 30 to 60%, although these are smaller studies with limited samples. So we know that a major function of RB is to regulate the cell cycle. Okay, so early in the cell cycle, what we see is that RB is not phosphorylated, and it binds very tightly to a molecule called E2F, which is a transcription factor. And once it's phosphorylated, RB then will then release the E2F transcription factor, and these E2F molecules then will bind to DNA and then activate downstream gene expressions. And some of these genes that are activated by E2F are these F-box protein called SKP2 and its companion protein called CKS1. And it's usually in a complex protein that we're going to talk about in a little bit. So in cancer, loss of RB or inactivation of RB means that we see increased activation of these E2F transcription factor, and that then leads to increased expression of SKP2. And these are the works actually of an Einstein scientist right here, namely Andrew. And I was very fortunate to meet him about 5 years ago and collaborate with him before he passed away recently. So let's talk a little bit about the UPS or the Ubiquitin-proteosome system. The system in the cell is actually designed to get rid of proteins that you don't need anymore. And the system is composed really of 3 different enzymes called E1, E2, and E3. It's the E3 enzymes that specify the protein to degrade, so it actually determines the specificity of the system. So therefore, if you can design a drug that targets a specific E3 enzyme that will selectively block, degradation of a certain protein, and then prevent the side effects of, just indiscriminately degrading other proteins. So one of the drugs that use this kind of paradigm is a drug called Velcade. It's currently used for myeloma, and which is very, very successful clinically. Some of these things may be applicable to sarcoma. So let's talk about the complex. I know this is a little bit complicated, but I think that, if you get the general concept, I think it's you got to be able to understand it much better. We talked about the E3 protein or enzyme. It's called an E3 ligase. It actually exists as a protein complex. We have many different proteins, and in this complex, the most well-known and the most studied is probably this SCF-Skp2 complex. And this complex is composed of a protein called SKP1 or Skp1, and then it binds to a scaffolding protein called colon-1, and then that whole thing then binds to this F-box protein called Skp2, and it is that Skp2 protein that then degrade other protein. In this case, it happens to degrade these two proteins called P21 and P27, and these proteins are very, very important in regulating the cell cycle. And if you, so what happened is, the tumor suppressor RB can actually inhibit the function of Skp2, both transcriptionally by turning the gene off, and also by coming into the complex itself, and then it physically displace the Skp2 protein out of the complex, and so it sort of turns off the complex. Now, unfortunately, in cancer, what we see is that there's a lot of inactivation or loss of RB. So when you lose RB, what you see is Skp2 level is going to go up, okay? And that makes sense. So when we look at osteosarcoma, what we see is that, sure enough, the level of Skp2 is very, very high, okay? When we look at both the cell lines as well as in the human tissues and the patient tissues. So this suggests to us that Skp2 may be an important regulator of this oncogenic process, at least in osteosarcoma, right? So what we did is we looked at a large data sets of osteosarcoma cases, and one of these data sets are called an R2 data sets. It's a data set from Europe. It's very popular for researchers to look at. We see that patients with high levels of Skp2 will do more poorly. And so the high levels of Skp2 predict a poor prognosis for these patients, both at the RNA level as well as a protein level. So since we now know that osteosarcoma express high levels of Skp2, we want to examine the effect of, what if we just inhibit or knock it down, see what happens. So starting with a couple of osteosarcoma cell lines in the lab, what we use a technique called short hairpin or shRNA to knock down the Skp2 level. What we see is that the cells start to undergo more apoptosis, and then when we inject these cells into the mice, we see that the tumor will still form, but the tumor volume will decrease significantly. And these animals can also develop lung metastasis. And sure enough, when we inhibit the Skp2, we see that we have much less lung metastasis in these animals. I mean, although this is encouraging, one can argue that these cell lines have been passaged for a long time, and so the results may not reflect a real life scenario. So we need really good models that replicate human diseases better. So to solve this, we have two main strategies. One is to implant patient tumor directly into SCF mice or immunocompromised mice that will accept human tumors. And this is the so-called patient-derived xenografts. So these tumors will grow in the mice. And, here at Montefiore, I'm fortunate that we have 3 sarcoma surgeons in a group, so we could collect tissues more easily and very quickly. So once we establish these patient-derived xenografts or PDXs, they can mimic a lot of the features of the original tumor, which is nice. And then not only that, it can vary from patient to patient, so it takes care of it replicates the heterogeneity of the tumor populations in each patient. And also, it's a good model to study the new drugs, so for preclinical testing of drugs. The second strategy is to create these so-called transgenic animals. These are genetically engineered animals that will have certain defects in tumor suppressor genes, and this is often the best way to study the underlying molecular mechanisms and to study the molecular interactions between pathways, and also is a good way to study familial cancer syndrome. So some of you know that some patients may have p53 mutations already, like patients in the Leaf-Lomé syndrome. This is also a good way to study the underlying mechanism. So since we know that knocking down of SCP2 or inhibit SCP2 seems to be beneficial, we're also interested in drugs that can inhibit this pathway. So it turns out that there are small molecules or drugs that can act in certain pockets or certain sites in the pathway or in the protein complex. So, for example, we have this drug that's actually is very interesting. It's actually from a root in the South Pacific that the local population had used as a tea. And we actually isolate this compound called FKA, or flavokawain A. It acts on an enzyme that put a group of compound called NED8 onto that SCP2 complex. And this is very important for the complex to work. And so if you have a compound that can inhibit that enzyme, then all of a sudden the complex can't work anymore. Okay, so that's one way of inhibiting that. We also have a drug that is currently on the market right now for clinical trials called pevondostat, which incidentally also inhibit that particular enzyme. And so this is a brand new class of drug that can do that. And then we have also drugs that are sort of in the preclinical stage, still being designed. There's a compound called C1 that actually binds to the pocket between the SCP2 and this companion protein CKS1, and that can inhibit the SCP2 protein from degrading E27. So there's a lot of different way that we can inhibit this complex. And so since both RB and P53 are often inactivated, right, in osteosarcoma, we want to see the effects of some of these drugs in the setting of having both tumor suppressor gene knocked out. So here you can see that using this compound C1 or FKA or pevondostat, we treat these are mouse embryo cells that either have the genes that RB and P53 deleted, or they have the wild type protein. And as you can see, these inhibitors are much more effective in inhibiting cells that have the deletions. So this suggests to us right away that cancers with RB and P53 mutations are probably more vulnerable to these SCP2 inhibitors, right? Which is nice. So to test this, one of our collaborators actually here at Einstein created a double knockout model, in which P53 and RB are both deleted, and these model actually developed prostate cancer. And these animals actually developed prostate cancer very early on, in very high frequency, and very, very aggressive prostate cancer. But as you can see here, what they found is that if you delete SCP2 or you inhibit SCP2, on top of that, these animals actually survive much, much longer. And in fact, they don't even develop prostate cancer. So in the setting of RB and P53 mutations, an additional deletion of SCP2 all of a sudden is what we call synthetic lethal, which means that the tumor cells now actually undergo much, much more apoptosis, and they actually can't even survive. So that is really nice data for us.
Hey, Dr. Hoang,
Yes.
I have a question for you. And at the very beginning, you kind of showed, the frequency of P53 inactivation and RB inactivation, and almost all osteos, it sounded like it was like, 90-95% have the P53 inactivation.
Right.
When you see RB1 inactivation, is there always P53 inactivation as well? Or do you see some cases where there's...
Yeah, so that's interesting, because most of the cases will have P53 inactivation already. And if you have RB inactivation on top of that, that will be sort of double whammy, right? So then some people, some patients also have multiple tumor suppressor genes inactivation. So in addition to P53, they may have RB plus P10, RB plus ATRX. So, there are combinations. So this model is somewhat, simplistic, if you will, because, we can, in the future, create models that are much more complicated with multiple tumor suppressor genes in activation, but, we have to start somewhere.
Right.
So, so this model, it's somewhat similar to human osteosarcoma. In fact, what I'm going to show you is that it's actually replicates human osteosarcoma pretty well.
I'm curious, because in the models that you were looking at, you had both P53 and RB1 knocked out. And so given that P53 is very common, right, and like 90% plus, I'm curious if you just looked at what happened with SCP2 and just P53 inactivation, which just to kind of...
so there are models in which you just have P53 inactivations, and then the P53 is inactivated in a different context, in a different pathway. You can also create osteosarcoma in those models. We haven't tested those models in terms of SCP2 knockout yet, but I suspect that SCP2 will probably be high there as well, because SCP2, in addition to being a downstream target of RB, it's also served as many other functions in cancer in general. And so RB is just one pathway, but there are multiple pathways that can control RB. So you're right, we haven't looked at just P53 alone, but I suspect that it's going to be very high in that setting also. So when we look at the RB and P53 in prostate cancer, like to show you, that immediately leads us to the hypothesis that maybe RB and P53 co-deletions may make osteosarcoma also susceptible to these SCP2 inhibitors, right? So to test this, sure enough, we create a double knockout model in which RB and P53 are knocked out, but in a setting of austerics. So you remember, I said austeric is one of those key transcription factors during normal osteoblast differentiation, during normal bone differentiation. So we only delete RB and P53 bone when bone is being developed in the embryo. We use this technique. And so these animals tend to develop osteosarcoma very early on, about 2 to 4 months of age. Now, that's the equivalent of about an 18 to 20-year-old human, since mice develop, they live much shorter lifespan. So this model, as you can see here, it replicates human osteosarcoma fairly well, both in terms of the histology as well as the radiographic features and the lung metastasis. This is a patient here, and you can see, these mouse model develop tumor fairly readily, and it replicates the human condition very, very well. So now that we've created the model, the next step is for us to, again, cross it into the SCP2 knockout, right? We want to see what the effect of knocking out SCP2 in this setting. And this will help us to answer some of the question whether SCP2 inhibitors are beneficial or not. And also it helps us to kind of answer some of the remaining questions regarding what are the downstream pathways that are affected when you knock down SCP2. So what we see here is the Kaplan-Meier survival. This is in mice. What we see is the addition of SCP2 knockout actually improves the survival of these animals by actually several months. And even though it doesn't seem like a lot, this is actually very significant because it is the equivalent of at least a few years in human, in patients. And this is due to the fact, like I just said, the mice age much faster than human. But the question is, why is the survival better? And perhaps even more important, why doesn't SCP2 knockout completely cure these animals, right? So perhaps there's some form of resistance when we introduce the SCP2 inhibitor. So for that, we turn to a technique called RNA sequencing. So some of you may know this already, but I just want to go through it just so that everybody is on the same page. So we know that RNA is the first step in gene expression, right? So you remember back in biology, go from DNA to RNA to protein, right? So now we can study actually gene expression in any particular tissue by sequencing all the RNA in the cells or in that tissue, right? And by sequencing the RNA, we can also count the expression levels of every single gene, okay? And compare that, which genes are active, which genes are inactive in a certain scenario. In this case, we want to know if we knock down SCP2, what are the genes that are turning on or off, right? So that will tell us what's going on inside the cells. Okay, so when we compare the original tumor, right, in these mice with RB and P53 mutations, and the tumor in which the mice have knocked out SCP2. So what we see is actually very interesting. We see many genes that are upregulated. So these genes are in red on the right-hand side, and many genes are downregulated. So, just in the interest of time, we just want to focus on one particular group of genes. And these are genes that has to do with macrophage functions. We see that they are significantly upregulated when we delete SCP2, okay? So this suggests to us a few things, but one thing that right off the bat it suggests to us that drugs that inhibit SCP2 is going to lead to somehow activation of macrophages, right? And so more macrophages is going to come into the tumor perhaps, and this is maybe the sort of prevailing mechanisms or the underlying mechanisms of why the tumors start to slow down, okay? So now this is just a hypothesis, right? So since more macrophages seem to be beneficial, at least in the mouse model, we see clearly that these animals survive much longer. We want to see if this is applicable to human. Okay, is this the same phenomenon can be found in human patients or not? So to do this, we turn to our bioinformatics colleague here. We have an excellent group of bioinformaticians here at Einstein to help us to do this. So we want to correlate the mouse data with real-life human data. And for this, we turn to the NCI Target. Some of you may know this database. It's publicly available. I think we have now, I think probably like 200 or so patients. 83 of them actually, when we mine the data, seems to have actually RNA sequencing data along with other data in the database. So we use a program or an algorithm called CyberSort-X, and that allows us to correlate the RNA changes in the mouse tumor and convert that to human genes, and can compare directly mouse to human. And we do see that more macrophage gene expression in human also means better protection. So if you can see here, if you dichotomize or if you divide the patient's group into high or low macrophage expressions, you see that clearly patients with the higher macrophage gene expressions also have a better prognosis. And so it's encouraging to us that we are on the right track, right? So inhibiting SCF2 means higher macrophage expression. Higher macrophage expression means better survival, okay? So this is, I know this is preliminary and this is encouraging, but we need more, right? We need to look further, just like any other research project. The more you look, the more complicated the picture becomes, right? So in order for us to sort of take a deeper dive into the mechanisms, and here we really, really want to hone down on the mechanisms because we want to understand why the tumor regressed, but also why tumor continue to grow even though they grow slowly, right? So in order to take a deeper dive here, we use a technique called single-cell RNA sequencing. And this helps us to determine the gene expression profiles at a single-cell level. Okay, so every single cell will have the RNA completely sequenced, and we know the gene expression of every single genes in that particular cell. Okay, so using the technique, the two things that we can do. One is we can use specific biomarkers that are known to identify certain cell types. And by doing that, we can actually divide up the cells into different groups. So it turns out the tumor contains many different cells. Like I just told you in the beginning, it's a very complex tumor microenvironment. It doesn't just contain tumor cells. It contains many different types of cells. And we can use this technique to identify not only the tumor cells here, but also the fibroblasts, the MSCs, plasma cells, the osteoclast, macrophage, the endothelial cells, and so on and so forth. Okay, so this is a very nice and very powerful technique for us to look really, really deeply at what these cells are doing in the tumor. And so these cells are invariably there to either trying to kill the tumor or trying to help the tumor. So we're in the early phase of trying to analyze these data. Obviously, these are massive amount of data. So it takes us time and money to try to do this. Suffices to say, I think at this point, what we can say is that we can identify not only different types of cells, we can also start to identify groups of cells that are most likely cancer stem cells. So I don't know if you've heard of cancer stem cells, but these are cells that can give rise to the tumor, and we can use certain bioinformatic algorithm to try to figure out, for example, using this technique called RNA velocity, we can tell like which cells are early, which are late in their development. And so the early cells are likely the stem cells, and the late cells are actually the tumor cells that are fully developed. And so I think that in the future, I hope that this will allow us to target maybe this early group of cells. And then, as you can imagine, if you can target cells that are very early on in their development, you can prevent all sorts of things, including relapses, right? So these stem cells can hide in your body after you're done with chemotherapy and whatnot, and they can recur, let's say, a few years later. So that's our hope. So I think, we have a lot to talk about, but I think that, this is, this is a good start. I hope maybe in the future I can come back and share with you more. So, in summary, we know that the SCP2 complex has many sites that you can develop drugs, right? These are druggable sites. You see that, SCP2 drugs hopefully can increase these macrophage, and macrophage seems to be a good thing. But there are many, many things that we still don't know, right? We still don't know what the relationships of these proteins interactions are in the complex, in the SCP2 complex. That needs to be gone into. And one of the ways that we are going to do that is to develop new mouse model, animal models with specific mutations in each of these proteins and try to figure out their functions. But, the ultimate goal is to, help patients survive longer, minimize resistance, and perhaps prevent relapses in the future. That's all I have. These are the people that I have to thank. There are many, many people that help us to make this work possible. Professor Liang Zhu is my idol. Unfortunately, he passed away a few years ago. He gave us all the mouse model. He helped us to develop the Osteosarcoma model and then all the other models. And it's been tremendous. It's been a great ride. Thank you for allowing me to share this work with you.
Thank you so much, Dr. Hoang. It's so great to have you on, and you did such a wonderful job explaining this. You are definitely a professor. Yes? You're really good at teaching.
Oh, that's what they call me. At least that's what they call me.
No, that's great. I think everyone feel free to add any questions to the Q&A. And Walker, I think you had a question.
Yeah, I can ask you a question. So you were talking about the macrophages, and I'm pretty sure those are just white blood cells, right? Or like that's a type of white blood cell?
That's right.
So could you technically just take from a blood donation, could you take somebody's macrophages and condense them and then give that to somebody so that way they had more? Or is that not a thing?
Yeah, so that's a good question. I'd actually never thought about that. If that's possible, that would be wonderful, right? So if you can take macrophages, let's say from a patient, right, and then somehow expand them and then reinfuse them into the patient so that now they have more, right? I think that anything is possible. We just have to understand, first of all, the types of macrophage. So it turns out that macrophages are not all the same. And so, we're just beginning to learn that, yes, there are more macrophages in the tumor, but maybe there are certain types of macrophages that are more beneficial, because we know that actually some macrophages are actually helping the tumor. So, so we want to pick the macrophages that are helping us fighting the tumor and try to get rid of the macrophages that are sort of like the enemies. So we don't know so much yet which one are which. And so those, remember I talked about the single cell RNA sequencing? We're hoping that by looking at just the subgroup of macrophages that we can identify different, subtypes. And after we identify different subtypes, maybe we can separate out the good guys from the bad guys. And then we take the good guys, we kind of like grow them up, and then we can reinfuse them in, kind of like, grow up the battle soldiers and put them back in. So, but we're not there yet. So I think it's going to take us a little bit more time and efforts to try to figure that out. But that's a good suggestion. I actually never thought about that, so that's good. Thanks.
Cool.
Very cool.
Biology major, University of Kentucky.
Keep up the good work.
So I'm going to kind of just back it up a little bit. I just want to, so, for p53 and RB1, for example, because they're inactivated, and I know there's kind of efforts to kind of look at the pathway because it's much easier to inhibit than to kind of try to turn something back on.
Yes.
But I'm just curious, like, is there any activity in that area of being able to actually try to turn things back on again? Or is...
Yeah. I mean, I think people have tried that for a long time. And if that's the holy grail of cancer, that would be it. I think it's very hard to turn them back on because there are so many ways to inactivate the gene that cancer is actually very smart. It has many different ways to inactivate a gene. And so if you try to turn it on by using one way, it will have a different switch to try to switch it off. And so it turns out it's very difficult to turn it back on. And once these major tumor suppressors are off, it's a big problem. And so that's why we're trying to look somewhere else to see if, despite having these defects or these mutations, can you do something to induce that synthetic lethal conditions by, knocking out some additional requirement genes that are required. Somehow you sort of negate the mutations, somehow like cancel them out. So it turns out that Liang Zhu hit it right on the head with SCP2, and he's the one that sort of, lead us down this path. And so, it's not quite as dramatic as what you saw in prostate cancer. I suspect because osteosarcoma is such a messed up tumor, if you will. It's very, very unstable genetically. And so it can have many different ways to try to escape whatever you're throwing at it. So I think it's very important to understand, how the tumor resists. It's even more important to understand the resistant mechanism than how to inhibit it. Yeah.
Right, because they'll eventually potentially just figure out kind of...
Right. Eventually we'll figure out how to escape it. Yeah. So if you can even plot that route, then, you sort of make it very difficult to escape, is what I'm trying to say. Yeah.
Yeah. Oh, Walker, do you want to take that question that just came in?
Yeah, there's a question in the chat that says, do you think that AI can accelerate osteo research, having in mind that so many researchers are working on this, and AI could combine all the data?
I'm glad somebody asked that. Somebody just asked me just last week, and maybe I should ask ChatGPT. Uh, so I'm always tempted to ask ChatGPT for my next question, so for my next grant, yes, the answer is absolutely, because I think that, there are patterns here, right? So one thing that AI is very good at is synthesizing information and looking for patterns, right? And I think that, until we can figure out what are the patterns of gene expressions or mutations that will behave a certain way, let's say you say, okay, if you have RB and P53 mutations, then you throw in SCF2 inhibitors. If you have P10 and RB, you throw in this other thing. So, AI can help you, I think, eventually to recognize these patterns and even suggest to you that, hey, if you have this pattern, this type of drug will more likely than not to work better than if you don't. So I think that's sort of the power of AI. Now, beyond that, can AI figure out, like how genes interact with each other or things like that? AI is only as smart as what you put into it. Also, as long as you have a good teacher, AI will be a good student. But, it requires that we have more information to feed to AI. So, but yes.
I'm so interested in if your future work will be kind of looking at these other different combinations of mutations. So, like you mentioned, ATRX, for example.
Yes. So
It'll be so interesting to see, what the behavior is in the pathway, depending on kind of what the driver mutation is.
So it turns out that, the more tumor suppressors are mutated, the more aggressive, right, the tumor becomes. And it becomes harder and harder and harder to block these tumors. We are in the process of trying to replicate some of these. It's difficult. And here, I have to stress that, we started this project about 4 or 5 years ago, and Liang Zhu started his, figure out all these pathways and all these mutations. It took him a good 20 years. And I came into the game, relatively late and was able to catch up because of, this is the typical, you stand on the shoulders of giants and you kind of see further, right? And you can, your research go faster and you're much more facile, right? So I think that in the future, if we can get all of these models to work and create them and then test them one by one, we'll get to the point where we can get very, very close to replicating the osteosarcoma in individual patients. And that's the hope. But I think that, to answer your question about AI, I think that, AI can help us to get there faster also. And then technologies like CRISPR, for example, you've heard of CRISPR, right? The gene editing technique, it already help us to accelerate, in terms of creating these animals. It helps us tremendously, make us a lot faster than we were before. I mean, leaps and bounds.
Yeah, because you can do these knockout models, right? Now,
Right, and you can do these knockout models now in a matter of months instead of years like before.
or even the single cell RNA sequencing, like that wasn't around 10 years ago, was it? Like you were
No, no. I mean, we didn't even know RNA sequencing was possible. And then, just to give you an idea, when I was your age, Walker, I actually worked in the lab and I actually sequenced DNA, and it took me 6 months to sequence a piece of DNA that will take the machine now about 15 minutes. So we've gone so far, right? And so, when you become my age, we'll see other things that are much more.
I was going to say he also had to walk to school in the snow.
Yeah,
So
that's right.
all those, yeah. So and for people listening, there was actually an osteobite. Dr. Juan and I were talking about this back in March, at the end of March 30th, I think, if you want to look it up on our channel. And it was Dr. Claudia Benavente from UC Irvine also talking about the same pathway of identifying a different protein. It was UHRF1 as potential target. And so I wanted to ask, I mean, this is just, osteo being so complex and kind of being driven by different mutations. I mean, there are a couple of ways. Obviously, you want to kind of attack it in as many different ways as possible. But I wanted to kind of ask about, the possibility of, and I guess, in humans without major toxicities, but being able to inhibit multiple targets on a specific pathway.
Yeah.
And or, once you kind of have a better idea of kind of what these different combinations of mutations and inactivations are, kind of targeting multiple pathways. So again, you're kind of like trying to block off any exits, right, for the stem cells.
Yeah, no, I mean, I think that the key here is to look at not only blocking different pathways, but also what are the side effects, right? What are the toxicity of inhibiting these pathways? So for that, actually having these mouse model are very useful because it sort of predict how your body is going to respond. So, for example, if you want to inhibit UHFR, you want to inhibit SCP2, so some other pathways, by creating these animals, it kind of forecasts what is going to happen if you inhibit that in human. And so if these animals become very sick when you knock out these genes, that will tell you this pathway is probably very essential. And if you knock them out, humans, patients can be very, very sick. So we were actually very fortunate, and I'm not sure if this is sort of by chance or not, but knocking out SCP2 actually is not very toxic to the animal. And that's how we were able to create all these models, and it's either, in any of these things, it's a combination of luck, right, and perseverance. So, there you go. It's it's not always just work. Yeah, of course, working hard is key, but having a little luck is not bad either.
Well, you mentioned that there were 3 compounds, right? It was the I'm not going to pronounce this correctly.
The Vondostat, which is on the market.
Yeah. So one of them is on the market, you said.
Yes. Yeah. So one of them is on the market. I think it's being trial. I can't remember whether they have clinical trials in solid tumors or not. A lot of these are being trial in lymphoma and leukemia and the blood cancers. They seem to work very, very well. Like I said, I think I mentioned Velcade for myeloma. That's sort of the go-to drug now for myeloma. And that's sort of the first generation of these proteasome inhibitors. And I'm certain that the drug industries are like hot on their trails of these things. and there are going to be many, many of them coming out in the next several years. And that will inhibit like certain, areas of the pathways and certain certain enzymes, to try to prevent the tumor cells from blocking the cell cycle regulation. And so this is a key area of research, not just osteosarcoma, but obviously in many different cancers. Yeah.
Great. The other thing I just want to note, I don't know if this is so much a question, just a comment, is just this kind of intersection, because when you were doing the single cell RNA sequencing and kind of seeing the different types of cells and noticing the increased level of macrophages, the good macrophages, this kind of intersection between gene expression and immune response and kind of immune signature.
Yeah.
Because I don't know, again, I'm not a scientist, but normally you kind of hear about them as kind of discrete things, and so kind of seeing this intersection and overlay of gene expression and being able to kind of determine immune signatures based on gene expression is really interesting.
Yeah. Also, we didn't want, when we first started in this field, we didn't think that this is going to affect the immune system. That was a complete surprise for me. And we thought that for sure, it's probably going to cause the tumor cells to undergo apoptosis, and, because you block the cell cycle and and lo and behold, it has something completely, a completely different effect. In that it influences the immune system, the white blood cells. I didn't show you the data on T cells, but it also increased the number of T cells. It increased the number of macrophage genes. It has very, profound effects on the immune system, which is a total surprise. But that's how research is, right? I mean, it's like, you never know. It's like, what is that movie? When he said it's like a box of chocolate, you never know what you're going to get, right? And you open it up. So.
Yeah, and it's also like the more you learn, the more you realize you don't know,
That's right. That's absolutely right.
Well, thank you so much. This was super interesting. And I do encourage everyone to catch that episode with Dr. Benavente, because I think both your talks actually really complement each other nicely in discussing the RB pathway. So thank you so much, Dr. Hoang, for joining us on Osteobites today and making it better for bone sarcoma patients everywhere. More information on this and all osteobites can be found on our YouTube channel, also on our website at mibagents.org, and you can also catch it at your favorite podcast place. And next week on May 4th, we're going to be talking to Dr. Janet Yoon from City of Hope. Dr. Yoon is a clinical professor and medical director of the Pediatric Musculoskeletal Tumor Program in the Department of Pediatrics at City of Hope, and she's going to be joining us to discuss a GD2 SADA 177-Lu-DOTA complex in patients with solid tumors known to express GD2. So please join us for that. And you can find our Osteobites lineup for the next few months on our website. And if you ever have ideas for future topics that you'd like to hear about on Osteobites, please send us a note at events@mibagents.org. Thanks again, Dr. Hoang and Walker.
Thank you.
Hour with us today. Really appreciate it. And we hope to see everyone back here next week when we talk to Dr. Janet Yoon. Thanks, everybody.